Welcome to part 4 of aging. This series of the PowerPoints is going to focus on sensory changes in the older adult. Our senses are important for our everyday lives. Our senses help us live our lives every day, and when we have alterations in our sensory functioning, we may not be able to do the things we once could, either temporarily or permanently. There are two things that need to occur in order for us to experience our senses. First, we have to have sensory reception. Sensory reception is the process of receiving data about the environment through our senses: vision, hearing, smell, taste, and touch. We use stereognosis, which is our sense that helps us identify solid objects by their size and their shape and texture. Like if we put an apple in our hand and we can tell it's an apple by the way it feels in our hand. We also use senses to help us orient our body. We use kinesthesia to help us know what position our body is in and how our body is moving, and our internal or visceral organs can help our body know where it is. Then we have proprioception, which is the subconscious ability to know where our body is in relation to space. Proprioception is what gymnasts has. They know exactly where their body is even if they're spinning upside down and sideways through the air. In order for all of these to work, we have to have a stimulus, something that's triggering our sense. Right now, I'm touching my keyboard. My fingers strike the key, and that pressure on my fingertips is the stimulus. My touch receptors in my fingers get activated and send a signal up my nerves to my brain, where my functioning brain receives and translates the nerve impulses into the sensation I feel on my fingers when I type. For all of this to happen, all of those things need to work, especially my brain. In order for the brain to receive stimuli and to respond to it, our brain must be alert or aroused. Alertness and arousal is controlled by our RAS system, our reticular activating system, not the RAS system like our heart. The RAS system is a poorly defined network from the hypothalamus into the medulla in the brain. The optimal arousal state is called sensory stasis, and it's when the nerve impulses reach the RAS and are perceived. The RAS will monitor and regulate all incoming sensory stimuli to maintain, enhance, or inhibit cortical arousal. It's a very fast-paced, constant process that's changing as the stimuli around us changes. When it comes to states of arousal, we can be conscious or unconscious. Conscious states include delirium, dementia, confusion, normal consciousness, somnolence, minimally conscious states, and locked-in syndrome. We've already discussed delirium and dementia and confusion. All of those have difficulties with orientation, memory, and changes in state of arousal. Normal consciousness is the state of being awake and aware of yourself and your environment and responsive to stimuli. Somnolence is when someone is very drowsy, but they still respond to normal stimuli. Someone who's minimally conscious is partially conscious. They have sleep-wake cycles and they have motor function, but they don't have complete control over their body and they inconsistently follow commands. Locked-in syndrome is a terrible disease where the person is fully conscious. They know and feel everything that's going on around them, and they have normal sleep-wake cycles, but they cannot move, cannot speak, and cannot respond to stimuli. Unconscious states include being asleep, stupor, coma, and vegetative states. Asleep is when we're sleeping, but we can be aroused or woken up by normal stimuli. Stupor is when we're asleep, but it takes extreme or repetitive stimuli to arouse us, like rubbing our knuckles on someone's sternum. Coma occurs when a person cannot be aroused and does not respond to stimuli, but does have reflexes like breathing and coughing. Much more about coma in later blocks. Vegetative state is like a coma, except they do a thing called posturing when they have noxious stimuli, and sometimes they have non-purposeful movement, but they are not there. Like they are still kind of in a coma state mentally. There are things that can happen to a person that can alter the way their senses are working. Normally, these things occur in our day-to-day lives, and they may ruin our day. They may make us grumpy and stressed out, but we adapt to them and we move on. To a person who is sick and in a healthcare facility, having so much happening to them all at once means they can't adapt and they can't move on to those sensory changes. Their senses go out of whack and they start having disturbances that may be mild or may become so severe that they become delirious, and then they have that complication of delirium. The first sensory altercation we have is sensory overload. This occurs when there is so much coming at them sense-wise that the brain can't respond meaningfully and they can't ignore it. They're being spoken to, poked and prodded, and there's noises everywhere, and everything looks different, and things smell, and they have lines and tubes and drains attached to them, and they have no sleep, and then they start to spiral out of control, and they go into fight or flight mode when they can have a whole range of emotions ranging from depression to panic to anger. To help prevent the sensory overload or to stop it from getting worse, nursing care should really focus on reducing that distressing stimuli and helping the patient gain control over the environment. Quiet times, having dark rooms, and giving them a break from their care can really help with this. Next, we have sensory deprivation, which occurs when a person experiences decreases in sensory input. They have the opposite issue. They get so bored from lack of stimuli that they get really drowsy and they start to have alterations in their sleep-wake cycles. They eat or they don't eat. They can get preoccupied with the time. They get preoccupied by body issues that normally wouldn't have been an issue, but now they're huge issues like my mouth is dry or there's a wrinkle in the sheet hurting my skin. And they may start to even have hallucinations and behavior changes. We can also have issues with sensory deficits, like vision issues, hearing issues, loss of taste and smell, and issues with feeling numbness and tingling or paralysis. They're not able to have normal senses, and they may have learned to adapt to those sensory deficits, like people who use hearing aids and wear contacts. But some patients don't always have them with them in the hospital, so sometimes they can't adapt to the sensory deficit. This can cause them to be sensory deprived or even sensory overloaded. And lastly, we have sensory processing disorders, which are difficulties with the way the brain processes and it organizes the sensory information it takes in. This can cause a person to have difficulty with interacting with their environment on a day-to-day basis, which becomes even more hard to do when they're placed in an unknown environment like a healthcare facility. There are several factors that affect the amount of sensory stimuli we need and want to maintain arousal. Our developmental stage will affect arousal and will change as our bodies and brains grow and develop. Infants and kids need more stimuli to help them learn and grow with skills and knowledge. And as we age, we start to lose some of our senses, like our vision and hearing, so we may start to rely on other senses to live and be aroused every day. Our culture affects how much stimuli we consider as normal and acceptable. Some cultures do a lot of physical touching and some do not touch. This can affect how much personal space a person requires. Our culture also affects how much rest and sleep, or the lack of stimuli, we want and need, as well as noise levels. Some cultures are very vocal and loud, and some are very quiet and hardly speak. Some of these are also part of our personality and our lifestyle. Some people have laid-back, quiet lives. They don't have a lot of stimuli in their lives. And some people like fast-paced, hectic lifestyles with lots of stimuli. Stress and illness and how we recover are greatly affected by stimuli. For me, I want quiet, but I have kids, so I don't ever get quiet time, but I might get less noise. Basically, I get a normal life when I feel sick. My husband has to be completely left alone in silence, and he will retreat to a bedroom for 2 days until he feels better. Also, some illnesses can affect our senses. COVID took away some people's taste and smell, and stuffy noses can make taste and smell go away. Diabetes can take away touch with peripheral neuropathy. Diabetic retinopathy can take away our vision. And some medications affect our senses and arousal, like narcotics that make us sleepy. Some antipsychotic medications can influence how our body perceives stimuli, and some medications have really bad side effects that can cause hearing loss. A lot of what we do in our normal assessments assess for sensory function. Speaking to our patients lets us know if they can hear us and respond to us. Checking orientation helps us know how alert and aroused they are. Having them do grips and pushes lets us know if they can follow commands and that they have motor strength. But sometimes we need to assess sensory function more in depth. We may need to ask them how they feel their vision is and if they use glasses or corrective lenses. We may need to assess hearing, usually by raising or lowering our voice instinctively when we talk to someone who we think can't hear us. To specifically assess the different processes in sensory processing, we can ask about stimulation, asking them how well they hear, how well they see, or how well they feel. To ask about reception, we should assess for anything that may interfere with sensory reception like glasses and hearing aids. We also need to ask if they use the glasses and hearing aids. Are they having routine vision and hearing checks? What do the people around them say about their hearing and vision? We want to assess if the person has the ability to react to stimuli. Can they feel things that cause pain and injury and move away from them? Like with diabetic neuropathy in their feet, they can't feel them. Can they do their ADLs? Can they drive and go to work safely? And if needed, we may need to assess for signs and symptoms of sensory deprivation and overload. Remember that sensory alterations can be portrayed many ways, like anger and hostility and depression. As much as we don't want to speak to somebody who's angry at us, taking a minute to ask them what's really going on may completely change the situation. Nurses have the ability and responsibility to improve sensory function. We want our patients to have the best outcomes, and sensory functioning is a huge part of that. We want and need our patients to respond appropriately to sensory stimulation while executing self-care activities, which means we may need to make sure they have their glasses and their hearing aids. We may need to have PT and OT come work with the patient, and we may need to space out their ADLs to not overwhelm them. This means we may need to teach the patient about their senses and about wearing their hearing aids and wearing their glasses. We may need to promote health literacy and help them schedule to go to their appropriate health screenings, especially if they're diabetic with their retinopathy and their neuropathy. We need to help the person stay oriented to time and place and situation by using the communication boards in the rooms, reminding them what day and time it is, trying to have very deliberate sleep and wake times. If we can have meaningful stimuli times that promote them staying awake, like being up in a chair, ambulating, having their family at the bedside, they may be able to sleep better during the times we want them to sleep, like at night, and that's really going to help them with their sensory processing and their healing. And this is the end of part 4 with sensory.